Hey everyone, this is Unit 8, Lecture 8, Treatment of Psych Disorders, and this is a biggie. It is highly likely that this will end up as two videos because this is a huge slideshow. It covers an entire chapter of your textbook, and I want to make sure you understand it well. I will do my best to keep it moving while not going too fast, so let's get to it. Learning targets include knowing a whole bunch of people, so anytime I talk about a big name, write it down. And we need to know the different approaches of all of the different approaches to treatment, and then a couple other additional objectives. In the past, in the great past, most people that had mental disorders were greatly mistreated, usually because of irrational views of what was causing their disorders, or that it was contagious, or that they would hurt people. And so many were subjected to strange, debilitating, and dangerous treatments, as we talked about in the first lecture of this unit. But Dr. Philippe Pinel in France and Dorothea Dix in the United States, that's a name we did learn about in Lecture 1 of Unit 1. She was pivotal in the United States, where they both made movements towards humane treatment of those with psychological disorders. So they worked to make sure that people with mental disorders were not just put in prisons or put in straitjackets or tortured and things like that. So they fought for the humane treatment of those with mental disorders. Okay, to give you a brief overview before I get into the nitty-gritty here, there's arguably three types of therapy that I want to focus on, like big overarching types of therapy. First of all, psychotherapy, and that's going to be most of this lecture if I do have to split it into two. This is an emotionally charged, confiding interaction between a trained therapist and a patient. So this therapist is trying to explore relationships of this person's past, encourage new ways of thinking, coaching them into new behaviors, things like that. So that's our first major overarching category. Next one is biomedical therapy, which if you're using my notes, this is like the second part of the second page. And this is when someone, or even third page perhaps, this is someone who's using medications, or a therapist who's using medications or procedures, often a medical doctor, that act on the nervous system to cure or treat disorders. So treating it just like, actually having a medical disorder. And then an eclectic approach, which is a little bit of both, using various techniques depending on the client's unique problems. So do you need to write this down? Not exactly, but pretty much everything in the first major chart of your notes is psychotherapy, and then everything in the second major chart of your notes is biomedical, and eclectic would be taken from both. Okay, so the psychotherapies, these are the four categories. These names should feel really familiar to you at this point. But one way to group it is to think of the psychoanalytical and humanistic theories as insight therapy, and this is the idea that a person's troubles will decrease once they are understood and resolved. So like if you have a unconscious conflict in your mind, when you are able to reveal it or work to reveal it and not have it be repressed anymore, you're going to have that insight that, aha, this is why I am the way I am, and you'll feel better and be cured. All right, let's kick things off with the first formal psychotherapy, which was psychoanalysis, developed by Sigmund Freud. Here is Freud's famous couch. In a psychoanalysis session, imagine laying down on this couch and starting to express your thoughts and just talking freely. Now, the therapist himself would be sitting behind you out of sight. So that's kind of a key feature, is that it was not face-to-face. The therapist would be out of sight. So psychoanalysis would be used to unravel the conscious mind and its conflicts. And as you just talked, that's called free association. You're speaking your mind and you're telling stories about your past. And the psychologist is asking you to say whatever comes to mind. At 1 second, you're talking about a dream. The next time, you're talking about a childhood memory, maybe something recent. And then the therapist is going to start to notice your edits. What do I mean by that? I mean pauses. I mean stuttering. I mean perhaps you're obviously leaving out details, or you make a joke or some sarcastic side comment. And you're resisting expressing a certain story or emotion. Those resistances are blocking your anxiety-laden information from your consciousness. So the psychoanalyst is thinking, oh, they stuttered there. Oh, they paused there. Oh, they left that detail out. They must be covering up a repressed conflict. And so the therapist will use interpretation to analyze those resistances, other significant behaviors and events, and try to bring to light underlying conflicts and feelings and so on. As the sessions continue, the client may act on positive or negative emotions towards the therapist. They might become very babyish towards the therapist. They might start to express love or more likely anger. And the psychoanalyst would think that this is transference, that they are transferring their feelings, love, anger, whatnot, that they actually mean to talk about in regards to another important relationship in their life, perhaps a parent, a significant other, an ex-significant other, and they are just transferring whatever those feelings are to that person. Criticisms of psychoanalysis. This whole process cannot be proven or disproven scientifically. When you're just making judgments about how someone pauses in their speech or the stories that they tell, how do you prove that they're wrong? How do you prove that they're right? How do you prove that the person doing the analyzing, the therapist, is right or wrong? Another criticism is that this whole process takes a really long time and is a lot of money for sessions, and it takes several sessions per week for years. Psychodynamic therapy is a little different. It's same general idea, but face-to-face, and it's focusing on the past and current relationships, not as much on things like dreams. And it is also considered interpersonal psychotherapy. It is considered quite effective for depression. And another difference is it's focusing on symptom relief now, not overall personality change. So in psychoanalysis, there's a greater emphasis of let's resolve this conflict so you can change who you are. Here it's more about coming to terms with who you are and what can we do to make you feel better right now. This one, typically people only meet once or twice a week for just a few months or periods. It's a little bit more a restrained version. And the focus also is gaining perspective on defended against thoughts and feelings. So when you start saying, oh, no, that was okay. Or, it's not like they meant to do that or say that. Exploring those sorts of edits. The next type of insight psychotherapy is humanistic therapies. And if you remember our humanistic point of view, our ring finger point of view, it's the idea that you are constantly trying to reach your best self and that you're inherently good. And so that's exactly what humanistic therapies aim to do, to boost your self-fulfillment by helping growth in self-awareness and self-acceptance. It focuses on trying to get the person to take responsibility for their feelings and their actions and not necessarily focusing on the childhood origins of their problems. So you might bring those up, those might be relevant, but they're not the focus. The focus is on the here and now. Basically, okay, those things happen to you, those life stressors happen to you. What are you going to do about it? It might go so far into having the patient actually suggest their own treatment plan in conjunction with the therapist. And it's not focused on the cure, it's more focused on coping and changing your way of thinking. It is also known as client-centered therapy or person-centered therapy. The humanistic approach was the first approach to not refer to people as patients, people with mental disorders as patients, but rather clients. You are seeking out our services to try to improve yourself. You are our client, not a patient that needs fixing necessarily. This was developed by Carl Rogers. He was one of our two major humanistic therapists along with Maslow. But Carl Rogers, if you recall, focused on getting a fully functional person through accepting genuine and empathetic environments. And so the therapist, a humanistic therapist, listens with these three guiding principles. If you remember the Cookie Monster video, there's our connection there. And this therapist would encourage clients to face their problems productively and try to help build their self-esteem. And they would actively listen. So instead of just taking notes, they would say, what I hear you saying is, do you mean this and this? That would be rough. That would make you feel good. So constantly feeding back, I am listening and I am working on understanding what you are telling me. I am not necessarily trying to get you to uncover something. Moving right along to behavior therapy. This type of therapy, so our behaviorists, you know which finger, that focus on what they can see, and they focus on learning and punishment and reinforcements. They aim to use learning principles to get rid of unwanted behavior. And they rely, if you think about your learning principles, operant conditioning, classical conditioning, behavior therapists rely on counter conditioning. And this is when you try to condition new and good responses to stimuli that previously triggered fear or bad behaviors. Stick with me, I'll give you a lot of examples to help you with this one. The first technique is exposure therapy, also known as flooding, and this exposes patients to fears repeatedly to lessen their anxiety. It's trying to utilize a process called habituation, and this is the diminishing of a physiological or emotional response to a frequently repeated stimulus. That's a mouthful, but it's the idea that by being exposed to something over and over and over and over, you almost, I don't know if you want to become numb to it, but you lose interest in it. You start to ignore it. And so, like, if your favorite new song isn't that great after the 500th time you hear it. So when you hear something over and over again, you lose that interest. You kind of get over it. So, like, if you're afraid of snakes, maybe exposure therapy would involve, like, seeing a snake and being around snakes over and over and over again. Kind of a more gentle approach to flooding is systematic desensitization. And this one actually makes a little bit more sense to me. It's like exposure therapy, but in baby steps. So exposure therapy, but you're associating a relaxed state with each increasing anxiety triggering stimuli. Why are all these sentences such mouthfuls? Again, commonly used for phobias. So the patient working with the therapist would establish an anxiety stimulus hierarchy. So here in my example, let's say you're afraid of public speaking. And so the patient themselves would rank some steps that would go into finally publicly speaking. And the patient would slowly be exposed to each level using relaxation techniques and stimuli to remain calm. So picking out your topic, remaining calm and doing some slow breath exercises perhaps, observing other people speaking, presenting alone, and so on. So each step, you take it little by little until you are calm and comfortable and ready to try on the next most intense layer, until finally you can do the thing that you have the phobia for. Another strategy of behavior therapy is aversive conditioning, also known as aversion therapy. Also a type of counter conditioning. So using some of our classical conditioning strategies that we should review. And you are associating an unpleasant state with an unwanted behavior. So let's use this little graphic real quick. Let's say you're trying to train yourself to stop drinking alcohol. You would take your neutral stimulus, which is that alcohol, and then you would add a drug which is designed to make you feel nauseous. So you've got your neutral stimulus being paired in acquisition phase, like every time I drink alcohol, I feel nauseous. Every time I drink alcohol, I feel nauseous, and so on and so on and so on, until you have now conditioned that alcohol to be a stimulus where you automatically feel nauseous just being around smelling or even the smallest taste of alcohol. So you can pair negative stimuli like that with smoking, nail biting, drinking alcohol, that sort of thing. And like, I know if you bite your nails, maybe you keep putting like gross tasting nail polish on your fingers. So every time you put your nails in your mouth, you're like, ugh, I don't want to do that again, until you just stop. So think of your classical conditioning techniques. It applies here. So unlike classical conditioning, where you are trying to teach your body to involuntarily reject a behavior, operant conditioning techniques are based on rewards and punishments and more voluntary behaviors. And that is focused on what's called behavior modification programs. And this is when a desired behavior is rewarded and undesired behaviors are not, or are even punished. So maybe think back to your elementary school days and you got a stamp or a sticker every time you did what the teacher wanted you to do until you had some money and then you got recess, extra recess maybe. That's kind of what I'm talking about here. And that's considered a token economy. So this is very common in an institutionalized setting because the therapist would have much more control over the daily actions and behaviors of your day. So if you are a patient in perhaps an institutionalized setting, like a hospital setting, maybe you get 2 stamps simply for getting out of bed. And then the patient would eventually take those stamps, tokens, chips, whatever, and exchange them for a desired behavior, a privilege, a treat, extra TV time, candy, free time, whatever. And so it's to positively reinforce those good behaviors. And remember, Reinforcements are what you do when you try to increase a behavior, and it's positively reinforced because something is being added to that situation. The criticism of this technique is that it's maybe too dependent on extrinsic rewards, because once those are taken away, perhaps the person will not continue that good behavior that you've just gotten done reinforcing over and over again. And is it potentially giving too much power to the therapist, where they are controlling the actions of their patient instead of the patient independently making adjustments and changes to their behavior? Studies have been done that show that this is a very strong technique with children, and it also works quite successfully with autistic children and trying to condition them, if you will, to certain behaviors. Next up is cognitive therapy, and when I ask you to think about cognition, you are thinking about thinking, and that's what cognitive therapy does as well. It aims to help the patient realize that their thoughts, feelings, and behaviors all influence each other, and that if that patient can shift their cognition, it will allow for emotional and behavioral changes to follow. So a cognitive therapist is going to help that patient learn how to control their thoughts and self-talk in positive ways. A subset of cognitive therapy is cognitive behavioral therapy, combining the two types of therapies, the one we just talked about and this one. That if you can alter the way people act and alter the way that they think, you can maybe lessen a disorder. So if someone is having self-blaming thoughts, and you can get them and maybe indulging their depression by not getting out of bed or not being motivated to mingle with friends, that perhaps if you can change the way that they think, that things are not their fault, that they're overgeneralizing bad things that will never get better, that if you can change those thoughts, then maybe you can encourage them to take different actions, perhaps going out and socializing, seeing friends, doing something that makes them happy, and then maybe it will alter the way they think. Okay, so cognitive behavioral therapy, trying to change someone's cognitions and their actions. Let's focus just on the cognitive part to see what I'm talking about here. If what the cognitive therapist is trying to do is change someone from thinking like this to thinking like this. So let's say you lost your job. Your internal belief, if you have depression, might be I'm worthless and it's hopeless. Self-blame and overgeneralization. However, with proper cognitive therapy, maybe you can shift your thinking to be, my boss is a jerk and I deserve something better. So I'm maybe bummed that I lost my job, but I'm ready to move on. So trying to change someone's thoughts, because then it could change their actions. So cognitive therapy is supposed to be particularly effective for depression, and the research into this was spearheaded by Aaron Beck, and he determined that depressed patients may believe that they can never be happy, that's their thinking, and thus associate minor feelings like even just failing a test, that event, as major causes for their depression. And so taking these small things and really blowing them up, and that cognitions would need to change in order to recover from that depression. That there's no other way around it. You've got to change the way you think. But the best way to do it is through gentle questioning, like trying to get patients to relate to how they did or did not contribute to that feeling or the thing that happened. And then try to maybe compare them to other people that went through the same thing and show them how their thinking is faulty, which leads to a very popular but a somewhat controversial therapy called Rational Emotive Behavior Therapy, REBT. REBT, yes, I said that right. It is extremely controversial because it sets up somewhat of a confrontational situation between the therapist and the client. And it's because the therapist is basically saying over and over again, you're being irrational. Your thoughts aren't valid. They are not logical. We need to change them. Almost like tough love, maybe? It's a little bit more strategic than that. But they're trying to show the patient their distorted thinking so that they can eliminate it. So the therapist is trying to get the patient themselves to challenge those illogical and self-defeating attitudes and assumptions. I'm not going to say shake out of it, but like, what else can we think? How can we oh gosh, this is a hard one to say, catastrophize your thinking. So if you're thinking everything's the worst case scenario, you're thinking everything's awful, what could we think instead? How could you shift it? So if you were to have lost your job, instead of thinking, there's no hope, this is awful, I'm never going to feel better, do better, be a success, whatever, what else could you say? So it's very, very controversial because it's intense. There are two last styles of therapy I want to touch on, of psychotherapy I want to touch on, and they can utilize a lot of these different approaches that we've talked about. The first one is group therapy. And the idea here is that clients benefit from knowing others have similar problems. So they would get together with 6 to 9 people, maybe have like a 90-minute session. It might be a little bit cheaper because they are sharing the attention of the therapist with others. But the idea is that they're getting feedback on new ways of behaving from people who are experiencing similar things, and maybe even people who are progressed a little bit further in dealing with some of these issues. And so they're not just getting feedback from a therapist, but other people who have been there. It's a way to help more people. It costs less. It is considered a cognitive therapy, but an outgrowth of the humanistic approach that it's about focusing on yourself and becoming your best self. And then family therapy, no surprise, involves your family. And it's treating the family as a system. So instead of a collection of individuals, that there's a system and everyone in that family has a role. Perhaps it's the caregiver, perhaps it's the breadwinner, perhaps it's the listener, the take charge person. And by helping everyone identify their roles in relation to each other, it helps improve communication between people. And the goal is to help people discover ways of preventing conflicts between each other, or healthier, better ways of resolving conflicts when they arise, because let's face it, conflicts arise in families all the time. And actually, this looks like a good place to pause. I am going to have a part 2, but I think it's going to be much shorter than this part 1.